Okay, let's move ahead to our next slide. Thanks for being here. As always, please introduce yourself in the chat. Thanks, Mary. Hi, Mary. So glad you're here. Nice to see everyone. If this is your first ever Connecting for Better Health meeting, welcome. We're so glad to have you joining our coalition call today. The vision of Connecting for Better Health is that every Californian and their care teams have the information and insights they need to make care seamless, high quality, and affordable. We start each of our bi-monthly meetings by reminding everyone of our policy priorities that we set collaboratively for the year. Our 2025 policy priorities are listed on the screen here: establishing DXF governance and accountability, identifying dedicated and sustained funding streams, strengthening social services data sharing, and advancing high quality and actionable data sharing. We can move ahead to our next slide. Really excited for today's meeting. We'll spend the first few minutes hearing about two recently completed community design studios that focused on medically tailored meals and medically supportive food, one in Alameda County and one in Petaluma. We're then really excited to welcome Melissa Buckley from the California Healthcare Foundation to share about a recent CHCF policy briefing and new publication. We'll wrap up today with a number of federal and California policy updates. As always, the last few weeks have been full of developments, and we're heading into the end of the California legislative cycle, so have some timeline updates and recent developments to share with you all. We'll wrap up with news, events, and announcements. As always, love to spotlight the work of our coalition members, featured publications, and upcoming events that you all are part of. So thanks so much for being here. Thank you for continuing to introduce yourself in the chat. Feel free to continue doing so as we move along in today's agenda. But with that, we're going to jump into our design studio report out. I'm so excited to hand it over to Maya Harrison and Toria Thompson. We're also joined today by Rebecca Murillo of the Alameda County Community Food Bank and Mary Dean of the Population Health Learning Center to speak a bit about these recent design studios. So Maya and Toria, it is all yours.
Thank you, Stephanie. I'm really excited to share that we have now completed two different design studios, one in Alameda County and one in Sonoma County, focused on medically tailored meals and medically supportive food. We've heard a lot of comments from our coalition partners that we want to really streamline and better connect food and healthcare. So I think that these use cases are a really good representation of the work that is being done in these counties. And I just want to call on Rebecca at the Alameda County Community Food Bank, who spearheaded the Alameda County Design Studio, to give a few words of why she was interested in joining our design studio.
Yeah, thanks, Maya. Hi, everyone. My name's Rebecca. I'm the Food as Medicine Program Manager at the Alameda County Community Food Bank. And this idea for the design studio really started in January during it was like a focus group session with the folks from CDII. And we are a medically supportive grocery provider in Alameda County. So there were some limitations we were having with access to data in our county, and especially noting that a lot of our referrals were taking a really long time to basically capture all the data that we needed in order to submit for authorization. And we were having several situations where we were going back and forth with different clinics to get, one A1C measure, one, BMI measure. And so I brought up in this meeting in January, like, wouldn't it be nice if we could have some more access to the data that we needed? As a medically supportive food provider, we do not have like an RD doing strict oversight of all of our patients. So I also thought it could be useful if there was sort of a minimum amount of data we would have access to that would allow us to submit a cleaner referral that's not also like 30 pages of clinical documentation, because we don't necessarily have all of that clinical experience to go through that and read it very efficiently. So I really brought up that idea of like, hey, we're struggling to get the right data from the right people. And I wanted to know if there was anything we could do to remedy that. And yeah, so that was the impetus of all of this. And I think we'll talk more about the results later.
Thank you so much, Rebecca. I'm going to highlight the food bank or the community design studio that happened in Alameda. Um, so as I mentioned, this was spearheaded by the Alameda County Community Food Bank. Other partners also included Alameda Alliance, the Alameda Social Health Information Exchange, formerly CDII before the transition to HCI, La Clinica, which is a local FQHC in Alameda that sends the referrals to the food bank, and Project Open Hand. So, as Rebecca mentioned, we heard a lot in the opening stages of our sprint process about the challenges with data exchange, which included, as Rebecca mentioned, how many of the clinical documents that are being sent from a hospital or clinic can be really lengthy and difficult to parse through for a CalAIM community support provider to really get the information that they need to help initiate the referral and authorization process by the local managed care plan. Another sentiment that was communicated was the lack of interoperability between the existing systems that were currently in place that in the past has led to duplications in food delivery or delayed services. However, I will mention that we were really encouraged to hear that a lot of the organizations at the table were interested in the process of were already in the process of updating their systems to have more automated functions to decrease some of the manual labor for their employees and have a quicker provisioning process so that patients can really begin receiving their medically supportive food or tailored meals in a more timely fashion. So based on what we heard, we created a persona named Carol Lopez, who is an example of someone that could be receiving medically supportive food or meals in Alameda County based on her diabetes of hypertension, or based on her diagnosis of diabetes and hypertension. We developed a user story that journeyed Carol through the process of being admitted to the local emergency department because of a foot wound that was likely caused by her undiagnosed diabetes. Then her local FQHC reaches out to Carol to schedule that post-discharge follow-up visit. At that visit, her PCP evaluates her and notices that her A1C values are high and then deems that Carol may be a good candidate for medically supportive food. We then detail the referral and authorization process for to get these boxes from the food bank. And then our final use case shows Carol going to the hospital again because she experiences shortness of breath and heart palpitations. And then we show that her current medically supportive food service is being put on hold. And then when she is being ready to be discharged, the hospital discharge coordinator is helping to initiate a new referral into medically tailored meals and nutrition counseling so that Carol starts to receive those meals right when she gets home. So anyone can access her whole user story that is now live on the Sandbox, and it is free to join the Sandbox. I'm sure Olivia will or someone on our team will put in the link to join. You can also find dataset requirements that detail the content that is needed in the messages being sent in the use case, and then also synthetic data that incorporates ADTs and the referral and authorization forms for this specific use case. Moving along, I just wanted to show a quick example of a data flow diagram, which is also part of the use case design process. There is a associated use case diagram for every scene that we write. And in this specific use case scene, it shows a managed care plan program manager that is receiving that authorization form. He approves of the service, and then we show how that system sends an eFax to the FQHC to notify them that about the approval, and then being able to really close that loop on the referral order. And then also that eFax goes to the food bank to tell them that they can go ahead to start provisioning the food boxes. We always try to ground the use case design process in reality, but then we also try to identify some areas where there could be new or improved data exchange processes, workflows. So everything in blue is technically new workflow. And you can see that throughout our use cases. And yeah, that is a little bit about the Alameda County design process. I'm going to pass it over to Toria, who's going to speak to a more similar design studio that was conducted in Sonoma County.
Wonderful. Thanks, Maya. Actually, before I jump into the Sonoma County one, does anybody have questions about the Alameda one that Maya just walked us through? There's a lot of detail we didn't share, and I do encourage you to uh, just go and join the link to the sandbox. It's just we'll just ask you for your email. We promise we're not going to send you anything, but you can log on, and when you do, on the left-hand corner, you'll see a link that says use cases, and there's actually that you'll see 6 or 7 use cases up there for different types of data exchange. We encourage you to go play around there, but you'll see the food bank one. But any questions about that before I talk about a similar design studio that we undertook in Sonoma County? All right, so let's take a look at this what we did here. So we're going to introduce Mary Dean from the Population Health Learning Center in a moment, but we are so delighted to be partnering with them. They're an incredible organization helping practices be able to improve the way in which they meet various quality measures, and she'll talk more about that. One of the things we are working with them on is these design studios for those practices in order to help them improve how they're exchanging data. We had the pleasure of working with the Petaluma Health Center, and particularly Dr. Oren there is a CMIO, very, very talented as both a medical professional and knows her stuff when it comes to technology. And she's a really forward thinker. And she wanted to bring a number of partners together to say, how can we make referrals happen better than they do now? So in her area, the QHIO that serves that region is Sac Valley MedShare. So they are contracted and members of that QHIO. In this case, the medically tailored meals provider that they contract with is Ceres. And there is also a referral organization, a nonprofit referral organization that does referral management in their region called Sonoma Connect. And so we brought them to the table. And of course, very importantly, the managed care plan. And the idea here being, how can we close a referral loop and make sure people are getting the services they want, in this case, the medically tailored meals, but also how can we ensure that communication is happening all throughout that provisioning? So in the case of this design studio, Ceres has a registered dietitian on staff. And so how helpful would it be for the primary care provider at the FQHC to be getting regular notes from the registered dietitian on how those visits are going? Typically, those notes are not things that are readily available. But in our design studio, we found a way through using Sac Valley MedShare where the notes can be bidirectional. The registered dietitian can see the notes when our persona Norma Garcia goes to the diabetic clinic at Petaluma, and the primary care provider, let's say, offers her an education, a series of education services on managing her diabetes. Then the registered dietitian can see immediately, oh, I see, Norma, you completed that. In module 2, remember how they talked about, the benefit of maintaining your blood sugar throughout the day? Well, here's what we're going to do. We've put in your food box this week these particular kinds of vegetables that help with that. And then when the registered dietitian maybe finds out that Norma's having a hard time with finding the time to cook the meals, and she can make some suggestions. And then the next time Norma comes into the primary care provider, that PCP will see what the registered dietitian was recommending. So for those of us involved in data exchange, it's basic 101 stuff, but it's not basic when you think about, Petaluma Health Center uses Epic. Ceres uses Salesforce. Is Series considered a HIPAA-covered entity? You know, that question, right? They're a community food provider. The registered dietitian is providing clinical services. They consider themselves HIPAA covered. They have the practices, but I think as a group, we're all still getting used to sharing healthcare data with what we might consider to be more community-based services organizations. So we tackled all of those kinds of questions in this design studio to find out what would need to be in place to make this process work. And then in here too, we have Sonoma Connect, which is a referral management system. So how do we have a referral from Petaluma to Ceres go through that hub so that everybody that uses that referral hub can see that Norma's receiving these medically tailored meal services and that the referral came from the primary care provider to Ceres, so that if there's questions, they know who to reach out to. So that's the other thing actually in this design studio, is that sometimes people don't, it doesn't, it takes more than 12 weeks of medically tailored meals to help somebody bring their A1Cs down from 9.5 to a more healthy level. And so one of the things that we heard from Ceres is that documenting the need for an additional set of 12 weeks can be challenging. Rebecca already mentioned that from the Alameda Food Bank, where she said, getting the clinical information, being able to see, well, what was her A1C value? So in this case, we have the registered dietitian is able, every time that Norma goes in to the diabetes clinic and gets her A1C taken, the registered dietitian is able to see that. She's able to see it move from 9 to 9 or from 9.5 to 9 to 8.5 to 8. And so she's able to write in her documentation to the payer, she's able to write, we've seen that this is working, but she's still at an A1C of 8. We'd like to see it go down to 6. Can you please reauthorize? And here is all the medical documentation you're going to need in order to see that that's going to be valuable. So having all of these players at the table, being able to all talk together, well, what would be needed? And is that okay? And what about this form? It's a 6-week process that, because everyone commits to every week for an hour coming to the table to talk this through, you can do a tremendous amount of trust building, systems work, and so on. And I'll just show you in the next slide one of the workflows that we enacted. In this case, the highlighted ones are the improved ones, right? So we as Maya mentioned, we ground what we do in the real world, meaning we're not going to just say, well, if everybody used Epic, we'd be fine, right? Like that's not going to happen. Or, hey, let's all use Fire and that'll make it all easy. That may come a time when that's true, and that'll be wonderful when it does. But how do we take one step and make it one step better? So, for example, the managed care plans are required by DHCS to fax back to the referring provider when the authorization is closed, when it's been approved or denied. How can we make it so that that e-fax that comes in to the FQHC, in this case Petaluma, how can we make sure that that can be somehow automated to close the referral in Epic? So we're looking at, how can we do that so it doesn't require a human intervention? So those are the kinds of things that we look through, and I invite you, you'll find this workflow as well as the entire user story up on the sandbox. So I invite you to take a look there. Any questions before we take a look at some of our learnings on the specifics of this one? All right, let's go to the next slide. I've already highlighted several of the learnings that we had, not just from the Petaluma, but also the Alameda County Design Studio. One of the things, again, Rebecca mentioned is that we are in the healthcare world, we're really facile at taking a CCD document, which contains sometimes pages and pages of clinical information. And if you're a nurse or somebody who is really trained in medical terminology, it's you know, cumbersome, but you can still find the information you want. If you are someone who's not clinically trained, as are many of the folks working at our community organizations, it can be a real daunting challenge to find the needle in the haystack you're looking for to determine whether this person is in fact going to be eligible for your particular service. So as Rebecca mentioned, in both design studios, mostly at her prompting, which we so appreciate, we came up with, is there a minimum amount of clinical information, some sort of subset, that if that were available, let's say through the QHIO, or in the case of Alameda, through the Alameda what's called their social health information exchange. If there was like a one pager, right, that had just the information that you would need to authorize a medically tailored meal, right? It wouldn't have necessarily information about all the treatment they're receiving for all their conditions, but it would just be enough to help you do that. Could that be helpful? And not just helpful at the community organizations, but honestly at the managed care plans. What we've heard is that the folks that are actually reviewing the authorization documentation are not necessarily clinically trained either. And so, and I see Michelle is on from the Food is Medicine Coalition. I'm not going to call on you since I didn't preempt you for it, but I know that Michelle has been working as part of the coalition that is supporting these medically tailored meals providers on, could we come up with some minimum data set that could be transacted? And that, you know, serves two purposes. On the one hand, it helps healthcare organizations feel like I'm not just over disclosing things, right? I'm disclosing just what's needed, right? HIPAA says minimum necessary. But it also helps on the community side of things where those folks aren't having to digest a huge amount of information and try to comb through what's relevant. So that was a huge learning and something we're going to continue to work on. And I know Michelle is working on as well as part of that coalition. I'll let you read these others. I think I've talked about many of those already, but I think we had a ton of learnings. And our hope by putting these use cases up on the sandbox is that these can now be spread far and wide. Every county in California, and actually in the country, could take a look at these to see if these would be helpful ways to improve their referral process for this particular type of service. Again, I'll just pause. Are there questions here or anybody have comments? I know we have several people who attended these design studios on besides Rebecca, but I'm curious if there's any questions, thoughts. All right, well, then what I would, oh, there we go. Yay, Michelle.
Thanks, Toria. I just would add that, you know, I find the medically tailored meals and medically supportive food a unique space in comparison to some other community supports, you know, and I could be wrong, but part of that is that you know, we are operating in this in lieu of services container, right? Where the services, there is the expectation that they are a substitution for state plan services. So that's pointing to the expectation that they have an impact on all, you know, several types of utilization. And the nutritional management of disease is an extension of medicine. And so this space walks into, and to specify in our community supports, it does not, we're not allowed to address food insecurity specifically or singularly, which would be the social determinant. So I think our organizations struggle because community supports are seen as this other service, but at least for the organizations, CalFIMIC organizations, we have 20 registered dietitians in our organizations that are providing clinical services. So they're all unique, and we understand the challenge of this space because some other medically supportive food may be a little bit of a different intervention and may not need the same level of clinical information, you know, that you know, Toria is trying to like get to. So I'm always available if anybody has more questions about this area. And thank you so much for your work.
Wonderful. Thank you for
Toria.
speaking up. I know you've been doing some incredible work to help raise the awareness of these organizations. So thank you, Michelle. All right, wonderful. I want to turn it over to one more person. I mentioned Mary at the beginning. Mary Dean is the Director of Programs for the Population Health Learning Center. And again, as I said, we're so delighted to be partnering to put on not only design studios, but our boot camps for the practices. So Mary, I'm going to turn it over to you to speak a little bit about the work that we are doing together.
Yeah, thank you so much, Toria, and thank you for the invitation to come and speak about our collective work together. But as Toria mentioned, my name is Mary Dean, and I'm the Director of Programs at the Population Health Learning Center. So we are the program office for the DHCS-sponsored Equity Practice Transformation Program. So we're working with nearly 200 practices and community health centers across the state of California to improve their quality metrics and disparity reduction. So part of that is how practices are leveraging data infrastructure and integration in order to meet those milestones. And so we've been really grateful to have the opportunity to connect with Connecting for Better Health. And as part of that initiative, we actually received some enhanced funding from Covered California to allow us to facilitate this series of design studios. So within equity practice transformation, practices, sorry, my dog just started barking, practices have selected one of 5 populations of focus. And so that would either be children and youth, pregnant people, adults with behavioral health needs, adults with chronic health conditions, and adults with preventive care needs. And so part of our hope for our design studios would be to focus on each of those populations of focus. So we were able to do the diabetes care focus with Petaluma, as Toria just described, and we're excited to be launching an upcoming series, both in this month and later in the year, to focus on the other populations. And we just wrapped up, as Toria mentioned, Petaluma diabetes care design studio, and it was so well received. The feedback we got from the participants were that they really feel like they couldn't have made the progress that they did without participating in that opportunity, and that they felt like it gave them kind of the tools in the understanding that they needed to make meaningful progress with that integration goal. So if you go to the next slide. Also, as Toria mentioned, we had the opportunity to work with Connecting for Better Health to facilitate a series of their DXF boot camps for participating practices. And part of the Equity Practice Transformation Program is working to integrate with a qualified health information organization. And so it was just a wonderful opportunity, I think, understandably working with the volume of practices within EPT. There is a varying kind of knowledge and understanding of what a QHIO even is, or how to get connected to one, what the best QHIO to consider might be, what the steps are for signing a data sharing agreement. And so we were really grateful that Connecting for Better Health had this program that I think really kind of perfectly responded to a lot of those common questions. And so based on that experience, we had a number of practices who were able to start establishing their connections with QHIOs, sign data sharing agreements. A high majority of participants found those sessions to be incredibly valuable. They rated it an 8 or higher out of 10 when asked if they would recommend those sessions. And 15 of the 45 practices that we had kind of targeted for this initiative ultimately ended up passing, so to speak, their deliverable focused on this milestone after participating in the session. I think that's it.
Thank you so much. I really appreciate your coming on, Mary, and
Of
speaking.
course. Thank you so
I
much.
think at this point, I think this is the last slide in our, or
I think we just
yeah,
wanted to pass it right over to Rebecca one more
of
time,
course, yeah.
just to wrap up what her the organization's next steps are in that design studio.
Yeah, thanks, Maya. I'm sorry to like backtrack a little, but
No,
I
all
did
good.
definitely want to share, some of our big learnings as a food bank, obviously from this design studio. We have undergone a Salesforce vendor selection process, and we are finalizing that vendor now. So a lot of the things that we've learned in this design studio, we're going to be able to take to that vendor to help us build that Salesforce instance that will be used both as a case management system and have like an eFax integration. So I think that has been a really wonderful learning, and I definitely wanted to shout out the team at Connecting for Better Health for gathering everybody together in this space. I mean, we did a lot of work in 6 weeks, and I can't say like enough nice things about how well facilitated it was and how useful it was for us too as a community-based organization to have like the FQHC and the MCP in the room as well. I think like I certainly learned a lot from those other organizations, and I think we were able to share in a less formal way than if we were on like a big meeting with a lot of people. So I definitely wanted to shout out that team, say that's a really big learning. And this has also definitely given me a lot more material to take to my leadership team, to be able to really get us like more seriously considering like how we can be involved in our social health information exchange in Alameda County, because I think before it wasn't as clear of a need for us. So I do really value all of that. So thanks again, Connecting for Better Health team.
Thank you, Rebecca. It was awesome to have you sponsor this design studio. I think with that, I'm going to pass it over to Stephanie, who is going. Oh, and then I just wanted to mention that we do have a lot of other design studios underway. Mary mentioned the other PHLC design studios, and then we also have one upcoming with the Archstone Foundation, and then we are looking to do one with the California Quality Collaborative this fall, focused on behavioral health. And then here's just a list of all the design studios that we have completed. You can find all of the use cases and artifacts in the sandbox. Happy to connect if anyone has any questions.
And I just want to do a big shout out to Holly Calhoun, who's from Project Open Hand, which was another organization that joined the Alameda Food Bank program, which was fantastic to have both of those folks at our design studio. I didn't realize you were on, Holly, otherwise I would have called you. She and her team were fantastic to work with as well.
Big thanks. Second everything Rebecca said, and a huge thanks to her for getting this whole thing going and including us. It was really a great experience.
Great.
With that, I am going to pass it to Stephanie, who is going to introduce our next speaker.
Thanks, Maya, Toria, and the whole team. Really appreciate seeing this list of our use cases grow, and they will continue to grow. Hope everyone is able to locate that use case library on our Sandbox site. If you have any questions about how to do that, don't hesitate to reach out to us. And as Olivia put in the chat, if you have an idea for a design studio or want to talk about what this might look like, please reach out to us at any time. Moving on to our next agenda item today, I'm so thrilled to introduce Melissa Buckley. Melissa is the director of the Innovation Fund at the California Healthcare Foundation. As many of you have seen or potentially attended, the California Healthcare Foundation recently hosted a policy briefing and has also published a new report and a few other publications this summer, all about data exchange. So Melissa, thank you so much for being here. We have just a couple slides, and we're so excited to turn it over to you to learn a little bit more around what CHCF has been up to this summer on data sharing.
Thank you, Stephanie, and thank you to the prior speakers. It's wonderful to hear all the work that's going on in the delivery system at the community level. You're our heroes, so thanks for the hard work. Just to highlight a little bit of what CHCF has been doing, to Stephanie's point, we were feeling that a lot of the research and work and conversation around data exchange has been focused on enabling quality of care and care coordination, which it should be. In the new era, where the Trump administration has us all very focused on affordability with HR1 and other policy movements at the federal level, we wanted to take a look to make sure the information we all are working with also has information about affordability and how data exchange systems can lend to efficiencies and affordability and how we're doing our work. I think that is one of the things that's now top of mind for everybody. We don't have a lot of time. We don't have a lot of extra resources. And so everything we want to be doing at the state level and in the delivery system, really, we want to focus on, of course, quality, but also on systems that improve efficiency and make more with the less resources that we have available. So over the summer, we did a quick sprint to update sort of the information that we all have at our fingertips from the last 2-3 years, where we had published a lot of resource for the data exchange framework planning groups. One of the reports that we put out is on what do we know in the research space and from looking around the delivery system in California about where data exchange systems can help with efficiency and save us costs. So we did 2 things. One is we put out this research report, and I can put the link in the chat, but also did a briefing in Sacramento to make people aware of what we've learned, and pulled together a panel of 3 folks who we discovered or worked with in putting the research together. They were a good mix, I think, of a primary care provider who used data exchange systems in his work every day and could talk to the efficiencies and the better care coordination he was doing because of data exchange systems. A hospital system representative that really works deeply with lanes, and so her care coordinators can really understand who the hospital folks are who benefit from social referrals and care coordination into their social needs. And Julia Adler-Milstein, who is a researcher, really preeminent person focused on interoperability data exchange across the country, who we use to really ground us in beyond California and beyond sort of our day-to-day. What does the evidence really say about how interoperability data exchange can support our work looking at efficiencies and cost savings? The recording of the briefing is actually on our website, and I can put a link in a second. It's we have often when we do events like briefings, we have the recordings available on our events page at CHCF, and I can put the link into the report as well. I think the takeaways from the report are highlighted on the next slide. And again, we talked to Julia in great detail about what the research suggested, and we reached out to folks in the delivery system about what they're experiencing real time. Julia made clear that the research actually has really good evidence on administrative savings that can happen through data exchange. That's the easiest place all of this is hard, as you know, if you're trying to prove something or do research in healthcare, because there's so many confounding variables and so much going on at once. It's always and data is limited. It's always very hard to sort of, for any real correlations or directional causations to rise to the data. So her standards are very high as a researcher. But the research really naturally does speak to the administrative savings from having people not having to chase down charts, for example, and to avoid duplicate testing. That evidence is pretty clear. One of the use cases that people speak to as really being valuable across the country are ADT sharing and transfers amongst organizations that are trying to do holistic patient care and care coordination. Before I move to the care coordination examples, the evidence is strongest where there's true interoperability. So as we all know, we're all really struggle with data exchange across systems and organizations, and there's so much friction. And so the more we work toward tight integrations and coordinated workflows, the savings and the impacts really become much more obvious. And so a lot of the research where these findings are more clear are places where either there's a HIO that's deeply integrated into a provider organization, or where the HIO is or HIE is being conducted through integrated systems. The care coordination use cases that we pulled or that our grantee found were examples, a lot of them, many of them were examples of where people are working in a CalAIM context with a qualified ECM, or people are partnered with HIOs, and that there is actually a good deal of experience where care coordination is, we know that care coordination is leading to lower utilization of ED and inpatient. That might not be like showing through yet in the research, but many people across California can speak to it. So, so I will provide links and happy to answer any questions in what we've found or are working on in this area.
Thank you so much, Melissa. I want to really just shout out the appendix of resources in this report on behalf of Connecting for Better Health. We're so grateful and have found that incredibly useful to have all of those in one place. And I know that so many of the folks on this call will probably love that as well. Would love if anyone has questions for Melissa, please feel free to put something in the chat or raise your hand. Melissa, one question from us, just in terms of where we don't have evidence that you'd like to see future research, what's top of mind?
You know, more of the same. As you could all imagine, we're just so buried in implementation of these things, and there's so many tactical things that we're addressing. And so I would just say keep building and keep affordability and measurement in your brains as you do the work. So if we could help anybody set up a system, a pilot, or any sort of initiative they're doing to capture some of those learnings, I think it goes a long, long, long way for us to be able, and Connecting for Better Health is always, asking for use cases and examples from real world settings. Our role really, besides supporting that work on the ground, is to bring it to Sacramento along with Connecting for Better Health. And it makes a real difference when they're thinking about budget and they're thinking about priorities. And so why we did it really was in the context of, the budget situation is precarious. We really wanted to not let folks not think about data exchange interoperability, because we think it is like just so critical to the foundation of us doing good healthcare and whole person care. And it's easy to deprioritize because it's such a mystery to so many people. And so we really wanted to keep highlighting that it's important. So I would just say, Stephanie, to your point, if you're doing work, let us know, and we'll look for ways at the front end or the back end to help capture stories and evidence that we can, raise to policymakers so that they keep giving us incentives and investment dollars to move forward over the next, many, many years as we make this what it needs to be.
Absolutely. Thanks, Melissa. I see one hand raised, and there's a question in the chat around how ROI is being calculated. Anything you want to weigh in there, or a particular link that you'd want us to pop in from the research on calculating ROI?
I would, Stephanie, to your point, look at the list of references. My experience, and I'm sure all of you have the same, is that in the end, when you try to say anything concrete about quality and cost, we all turn to you can only learn those things in very specific context. And so you got to dig into the research, and it's usually like a very specific use case with a very specific measurement. And in general, in academics, you have to boil all these things up into like big takeaways and learning. So to the question of how people are measuring ROI, there's a zillion different ways and a zillion different studies that are trying to get at that question. But as you would imagine, there's an example, I think, in the report of Manifest talking about it in terms of human labor hours saved chasing down charts, or there's other studies out there that calculate it by looking at in controlled populations reduced ED utilization or inpatient admissions. So those are just two examples of the ways people try to get at these challenges, and it's sort of the controlling for all the other factors in the world is always hard.
Right, absolutely. Janine, you want to introduce yourself and your organization and ask a question?
Yes. Hi, I'm Janine Spotnitz. I'm a health program manager with Sacramento County Department of Health Services, and I'm overseeing the build of our social health information exchange. And I want to first thank you for this report. It is very timely and helpful for us. And if, Melissa, if you were offering CHCF support to help us capture the affordability and cost savings, we would greatly appreciate that because we're at the stage of trying to struggle to get ongoing funding. And if we're able to demonstrate that, that will help us incredibly. So I just wanted to appreciate
I'd love
your
to have
work.
a conversation. And
Yeah.
yes, I think, we really need evidence. So, and that's right. Like we all need to have better concrete evidence in healthcare to be able to guide all of us in where we should be prioritizing and spending our money because it's important and there's not a lot of money. So yes, please reach out to me. I'm at mbuckley@chcf.org and let's have a call.
Thanks, Melissa. And thanks, Janine. We're excited to welcome you back to C4BH in the future for a presentation on how your work's going. Okay, last question before we'll let you go, Melissa, from Robbie. Are there evaluation frameworks that researchers recommend organizations use?
I, again, would imagine all of this goes back to what specifically we're trying to measure. We actually at CHCF worked with the Kaiser evaluation team, which is CCHE. I don't know if people have run into Maggie Colby. She's fantastic. And did an evaluation sort of toolkit that we have like a 10-page version and then like a 100-page version of how folks approach evaluation. In the end, it's, just specific. You have to think about what you're trying to demonstrate and what the value chain is to leading up to that change, and then develop sort of your outcome process and outcomes measures around it. So there is a toolkit if you search evaluation, CHCF, and CCHE that we've done, and there's lots of other resources. Happy to talk more about it on a call.
Thanks so much, Melissa. Yeah, we'll see if that's a link we can pop in or share our website materials as well. We'll appreciate this so much. Thank you for all of your work, your support of so many people on this call's work, and we really appreciate you being here today.
Thank you.
Okay, our last few minutes of the call today, we have a number of California and federal policy updates. We'll move quickly, but want to get through a lot of this. Coming back to our California legislative process, our Assembly and Senate are back in session and in the home stretch of this year. Tomorrow, August 29th, is the appropriation suspense hearings for both the Assembly and the Senate. Tomorrow is the deadline for fiscal committees to hear bills before they go to the floor. Senate Bill 660, the Menjivar authored bill C4BH is sponsoring on the data exchange framework, is on the suspense agenda for tomorrow in the Assembly. I'll put a link to the Assembly Appropriations Committee in the chat now. If you're interested in watching the suspense hearing, they don't present or deliberate on each individual bill, but just read off the bill numbers and if they're moving forward. As a reminder, if the bill makes it through appropriations, it then would go to the Assembly floor. The deadline for both houses to pass bills for this session that will make it to the governor is September 12th. And then Governor Newsom has 30 days to sign or veto any of those bills. So over the next 2 weeks, the bills that will make it to the governor's desk, it will be a far pared down list compared to what's up on suspense tomorrow in both the Assembly and the Senate. We'll have to pass that hurdle. We'll be watching tomorrow, posting on our social media updates as the suspense hearing happens. I'll put this link in the chat to the Assembly Committee on Appropriations. This is where the bill is. If you are represented by a member on the Assembly Appropriations Committee, today would be your day to make a phone call if you'd like to call and say that you support Senate Bill 660. Phone numbers are all listed here next to the members. Reach out to us if you have any questions about that at all.
Okay, in the interest of time, we're going to move really quickly, but the next couple weeks are going to be fast and furious. So we'll make sure folks get updates on bills. We have our tracker here. We won't go through this today. The majority of these bills are on suspense file for tomorrow in either house, meaning that they will get determined if they're moving forward or not tomorrow. So the next time we meet, we can expect that this list will be quite pared down. But with that, I think really quickly, Olivia, I'm going to hand it over to you to share a quick updates on our state and federal. Go ahead, Olivia.
Sounds good. Hi, everyone. Happy to be here today. Just a few quick updates that we want to get through. I think first, making sure that it's on everyone's radar that the DXF policies and procedures are going through some administrative changes. A public notice has been released and comments are due by September 2nd. So that'll be Tuesday of next week. C4BH, these proposed administrative modifications really are to address the DXF transitioning from CDII to HCI. And the modifications are all replacing references from CDII to HCI and then also granting HCI the ability to maintain programs that were established by CDII. C4BH has submitted our support of these administrative modifications, and there is a form where others can do so as well or raise any concerns that they may have. Next update, coming out from DHCS, we want to make sure that everyone is aware that toolkits have been released related to the data sharing authorization guidance, which is a great resource that's available to help organizations navigate the big web of state and federal data sharing and privacy laws that we have to enable information to be shared. These two DSAG toolkits, one focused on Medi-Cal housing services, and then also another one focused on the Justice Involved Reentry Initiative, were made available last month. And these help to really illustrate the scenarios if and when consent is or is not needed. The state has also signaled that they are looking to develop a children and youth toolkit, so keep an eye out for that in 2026. And we are really excited for these updates and thank DHCS for their efforts here. Also want to make sure that folks are up to date and aware that the Ask Me Form 2.0, a standardized consent form, is available to help organizations share sensitive information. There are two versions, one for AB 33 and one that's non-AB 133. Basically, if you are in Medi-Cal or not Medi-Cal, there are two versions available. And this form has been updated based off of the pilot form that we used back in 2023. Next slide, Maya. C4BH has also submitted public comment in support of the Medi-Cal Transformation Concept Paper that was due last week. This paper outlined next plans, or the state's plans for CalAIM and the Medi-Cal waiver renewal process. We were excited to see that increasing data sharing was included as one of the goals for continuing Medi-Cal transformation. And C4BH just called out the opportunity for stronger alignment between DHCS programs and the DXF to really see this through, and then also opportunities to learn from all of our use cases that are available in the sandbox and are really driven to support, and many of them are really focused on supporting CalAIM. All right, and just a few more, I think we're moving over to our federal updates. Want to let folks know that Dr. David Hunt, the HCP Medical Director of Patient Safety, is going to be joining our second coalition meeting in September, so that'll be September 25th. And we're so excited and pleased to have him join us to come discuss HCP initiatives and priorities moving forward. On that note, I just want to make sure that people have seen that the new HTI-4 final rule is available, which focuses on prior authorization and also electronic prescribing. So it updates standards that are used for electronic prescribing. It adds in a new real-time prescription benefit tool that can help providers at point of care compare costs and coverage information around prescription drugs. And then this rule also includes API criteria, FHIR-based API criteria on a few different areas. And these align with the CMS final rule for prior authorization that was released last year. So excited to see this update. And then one final one focused here on TEFCA. There is also a public feedback request that has been released around the government benefits determination exchange purpose SOP. This is one of the exchange purposes one of the 6 authorized exchange purposes under the TEPA framework. And they are developing this SOP to enable federal, state, local, and also tribal government agencies request to receive health information to make determinations about an individual's eligibility for different government benefits. And recently, I believe earlier this week or late last week, this open call for subject matter experts became available from TEPCA, welcoming people to raise their hand to come participate in various work streams. You do not have to be a TEPCA participant to come participate, but they're looking to bring in some more experts to help support TEPCA development moving forward. And I think that is it in regards to our state and federal policy updates. Sorry for having to run through those quickly, but our slides will be available online after the meeting with lots of links in it. So they will be a great resource moving forward if you have any questions. And with that, let's wrap up the meeting with some news, events, and announcements. I'd love to hand it over to my colleague, Julia, to talk about the Health and Homelessness Community Practice update.
Thanks, Olivia. Hi, everyone. Just a very quick plug here for our Health and Homelessness Community of Practice, which we launched on August 1st. We're hoping everybody will join the community, and we'll share an announcement next week about how to sign up. And then we'll be having an informational webinar on September 9th. Please join. You'll learn more about how to actually join and participate in the community of practice itself, where we'll work together with continuums of care, managed care plans, and other partners to solve issues that prevent those who are experiencing homelessness from receiving needed enhanced care management and community supports. So we're excited, and thank you also to CHCF, who've provided some support to help us with the recruitment and getting this off the ground. And with that, I'll pass that back. Thank you.
Thank you. And I think Maya's pulling some links to pop in the chat here around how to register for the upcoming webinar, office hours, and then we also have a great 2-pager on what the housing COP is. We also wanted to call to attention a new op-ed that C4BH Coalition partners have put out around healthcare budget cuts, rates to call for improving data sharing. This is a joint effort between Anika Chaudhry of Alameda County's Social Health Information Exchange, and then also Dan Chavez of Serving Communities Health Information Organization. We can add this link to the chat, but they bring attention to the need for having stronger state governance and enforcement to support broader participation in California's data exchange framework, so that California can really fully realize the benefits of a coordinated and efficient health system with data sharing. And then also lots of other news has been included in our newsletter. So welcome folks to sign up there. And yes, great op-ed. I thought it was very well written, makes that connection to affordability, high quality, accessibility, and great timing with it as well, right before the appropriations hearings coming up later this week. I think with that, we'd just like to wrap up the meeting with spotlighting some upcoming webinars and events. Civitas is coming up soon. I think we'll see many coalition partners there, so excited to see some folks in person. C4BH will also be at CAP later that week in Palm Springs. Also, CHIAC has their annual conference in Palm Springs, so we're excited to see you there. And Timmy, I believe, will be speaking at the State of Reform Conference as well the following week. So we're excited for conference season coming up and look forward to seeing so many of our partners in person. Yes, and then our dinner. Hope everyone has it on their calendar and stay tuned for more updates. We are gearing up for it and excited to celebrate milestones and momentum as the theme of the dinner.
Thanks so much, Olivia. I think with that, we can go ahead and wrap up for today. Thank you so much to our guest speakers who joined us. Really fantastic to welcome you. Thanks all for spending your hour with us. We hope you have a great rest of your Thursday and a wonderful long weekend. Happy Labor Day. We'll see you in September. Bye all.